So it fills us with a lot of immense pride and also humility. Humility that our people expect more from NHIMA. Yes, at the beginning, we had pockets of resistance around, one, what the scheme stood for, what the scheme will achieve, but above all, there were different voices on how the scheme should be implemented. When government noticed that there was consensus on the intention, on the benefits of a scheme, government decided that it was now time for us to proceed to implementation. Now, there were broadly three areas of conflict, three areas of difference. Sure. Number one, the stakeholders were saying, DG, this is just for civil servants. We want you to assure us that this is for every Zambian. Secondly, there were challenges around accountability. Sure. Is this another toll gate? Is this another fee, is another tax that you are imposing on us? And finally, the public have had experiences in the past where programs have been rolled out and they've taken long to mature. And so they were saying, can you assure us that the project is different? Our approach was that, first of all, it's important universal health coverage is achieved in our lifetime, because from historical data we discover that under the Abuja Declaration, government needed to invest upwards of 15% of GDP into the health sector. It wasn't happening. And the reason it was not happening, the reason the health sector had less than optimal funding is because there are other competing demands that are bequeathed on government. And so NHIMA then was birthed to come and create a supplemental source of innovative finance to the hospitals. And 1.5 years down the road, we have proved, and we continue to do that to stakeholders, that there are more members of NHIMA than civil servants. For those that are formally employed, we have time and again gone back to them and said there are more and more informal sector people that have started coming to the authority. Accountability, Innocent, has been a big, big issue. You will recall that we have decided as NHIMA to periodically announce how much money we've collected. You probably don't hear that from many institutions in my position. And this is deliberate from the board of NHIMA. We let you know how many people have been registered almost on a monthly basis, how much money we're collecting in broad terms, how much money we are investing in hospitals, how much money we are investing in systems, so that we can continue to engender a culture of confidence in our people that their resources are being prudently managed. And of course, the issues of service. Will NHIMA impact notably on health service delivery? This is the elephant in the room. And I've just finished with my team a nationwide long-year tour of all the selected facilities. And I can proudly report to the public, we are not yet where we desire to be, but we have moved from where we were at the beginning of this project.
Fantastic. Before we get to the issues to deal with accountability, this is one critical component in our country. When you talk about accountability, really, people, it's like a lot of citizens today as we speak, they seem to have lost interest, not even support to public institutions because of the so many scandals that we've had in the past and the likes. And when we talk about NHIMA and the other institutions, they feel that maybe these are just one of the institutions that want to extort money from us or to siphon money from us, just like you mentioned in your preamble. But before we get into the intel of that story regarding the accountability, I want you to just to help the people of Zambia with regards to how these achievements you've just mentioned in your preamble have been made possible. And if at all you are going to answer that question in a faithful manner, I want you also to go further if at all there are other things that you anticipated or you anticipate to achieve through the help of the people of Zambia.
Innocent, we had what we call the Big Five. Big five things that we needed to quickly and promptly work on. The first thing we needed to do once we got into office was for us to set up structures. Structures were important because under Section 4, the National Health Insurance Act establishes the National Health Insurance Management Authority, deliberately separate from the Ministry of Health, as a special purpose vehicle with a Chinese wall, a firewall around it, specifically to protect it from the public's, and I would say the public sometimes are justified in assuming that there are challenges of accountability. But government knew that this was one of the key question marks that was imposed on the authority. So they deliberately created the National Health Insurance and carved it away and created a Chinese wall around it, separate from the ministry, independent, so that its resources and its processes can be easily accountable and transparent. And so the first thing we needed to do was to set up the structures.
Meaning you are independent from the Ministry of Health?
Yes, we are.
All
yes,
right.
We are. And government
How
was
is that
deliberate.
possible? Because you are all dealing with matters of health.
You see, Innocent, there are structures that you use to create what are called bodies corporate. And so the drafters of the act were very deliberate. Government was very deliberate. They had listened to the people's submissions during the process of creating this law. Through Parliament, people submitted and said, we want this body, we want this authority to be set apart, to be different, to be accountable to the public. And government listened and said, we're going to then, under Section 4, set it apart as a body corporate separate. Now, this is important for our people to know, because when I talk about accountability, I mean that when you send your kwacha to NHIMA, that kwacha doesn't go into government coffers. It goes into NHIMA coffers. The board of NHIMA, comprising stakeholders from all 14 key stakeholders, then gives the DG a budget to make sure that the resources are properly accounted for. So we started as a matter of agency to create the structures. There is a board which the minister appointed, then Director General's office has other directors who are running directorates. And Innocent, the board and government said, DG, if you think that the best resources are from private sector, go and get them. If the best human resources are in public sector, create the best of both worlds. So we've gone ahead and created this structure. As we speak, we have close to 40 people that are working in the structure that are both from public and private. This is how we have managed to do some of these works. Secondly, we needed to go and start registering members. So 1st of October, we started registering and collecting contributions.
That was last year?
The other year, 2019, October 2019. So the deduction started percolating on your payslip.
Right.
1% of your basic pay. In the last 1.5 years, we have collected upwards of 1 billion kwacha, and these monies are properly accounted for. Of course, we needed now to register you as a principal member and make sure that should you go to a hospital, you'll be attended to. Innocent, we've registered upwards of 1 million principal members as we speak. For every principal member that you bring on board, you then can bring your spouse, you can bring 5 of your children or dependents. That speaks to one of government's major reasons for creating.
When you say registering principals, in simpler terms, because for the benefit of our grandmothers in Kanchibiya, in Lundazi, people in Southern Province, that are failing to understand these technical terms you are using. Try to simplify it further. Because this scheme actually benefits the ordinary citizens there.
Correct.
We're not segregating at all.
Not at all.
Just try to simplify what you're talking about.
So under the Act, Innocent, And I know that people from Chipata, English is a problem with them. So, under the Act, Innocent, there is one member who is making the payment.
Right.
Okay? In this case, Mr. Piri. Mr. Piri is a principal member, is a member who is making the payments. So from the age of 18 up to 65, every Zambian who is in gainful employment is required to make a contribution.
Right.
So it's like you now have the main account. Then with that contributor, Mr. Piri, the Act says Mr. Piri can now bring a spouse, one spouse, not other spouse, just one, official spouse, the one we know.
Not extended.
Not extended. No nguzos, not at all. And once you've brought in your spouse, so it could be Mrs. Piri who is registered, then she can bring Mr. Piri on the account. Then we are saying Mr. Piri may now have at least 5 children or 5 dependents or beneficiaries. They are also put on your account. So you are not going to the hospital alone. You are going to the hospital plus the other members of your household on one account. Innocent, we've registered over 1 million people as we speak. The other thing we needed to do was now decide if you pay 1% and you bring your dependents, what are you going to find at the hospital? We then set about to create what is called a benefit package. As we speak today, Innocent, there are over 177 conditions or diseases. These are the diseases that we created, that we designed, that are nearly all the disease burdens that you can find in our hospitals and in our country. So on the 1st of February 2020 last year, hospitals started receiving our members to now go to the hospitals and get treated on NHIMA without paying. The other big thing we did in the last 1.5 years since we were last here was to now again agree which hospitals are fit to join NHIMA. Remember, government is saying we want higher quality of care. So not every hospital can qualify to come onto NHIMA. So we set about to say what are the conditions, what are the questions at the hospital, how many workers should they have, can we accept a 1-bedroomed house as a hospital? I know there are a lot of so-called hospitals in a 1-bedroomed house. We were therefore saying, how can we make sure that we protect our people and only allow proper facilities to join us? In January 2020, February 2020, hospitals started providing service. Innocent, in September, because we had started with public hospitals, in September we opened the window for private pharmacies. So private pharmacies in September started joining the NHIMA family of healthcare providers. In January this year, the board said, DG, we now need to open the window to private hospitals.
Right.
So as we speak, we have a double dozen private hospitals and pharmacies, eye hospitals that are about to join the extended NHIMA family. These are some of the things that we've been working on, Innocent, in the last 1.5 years.
Right, thank you so much. With regards to the numerous achievements that you've achieved in the last maybe 2 to 3 years now, I believe that such kind of immense achievements cannot be done or cannot be realized without the partnership with other private institutions. You know, how much support are you getting from the private institutions as well? You know, like you mentioned in your own, that sometimes you find that people, they just look at NHIMA and say, this is one of the government institutions. You know, how much collaboration do you get from the private institutions?
Massive, massive collaboration. Innocent, a project this size, we've said this time and again, this is one of government's most ambitious and most impactful project in the Ministry of Health. Because its intention is to ensure that from the moment you are born, the same way you would not drive a brand new vehicle from the showroom without insurance.
Sure.
To take it on the road. Government is saying you should not, when you are born at UTH, you should not leave the ward without insurance.
Right.
So we don't want our babies in very soon from now to leave a ward without health insurance. So it's massive from the moment you're born to the moment you die. Massive project. Now, a project this size requires the goodwill, first of all, of the citizenry. Innocent, our people have been patient. Our people have been trusting. And we can proudly say that their trust, their patience was not misplaced. As we speak now, as more and more of our people start to taste the benefits of NHIMA, as testimonies, people have started talking to each other about what happened when they went to UTH and were received by our member service assistants, how they thought they would pay an operation bill of 20,000, and someone said, no, you're on NHIMA, and NHIMA took care of that. How many of our people we are looking after for renal dialysis? How many people we are supporting through orthopedic implants? So the community is now abuzz with what NHIMA is doing. So the first and most important stakeholder has been our people, our contributors who've been contributing into the fund, who've been patient. We're very glad that soon and very soon, gradually, their patience is being rewarded by the fruits of this scheme. Number two, government has been very supportive, Innocent. Government through the Ministry of Health has continued to support us. Remember that we work through hospitals, which are managed by the Ministry of Health. And like I said, we're separate from the Ministry of Health. We've signed contracts with hospitals. We've signed contracts. NHIMA has signed contracts with the Ministry of Health in terms of the minimum standards that we expect in the hospitals. So the Ministry of Health has been, as a mother ministry, has been very vital and critical in these milestones we've achieved. Ministry of Finance to support us. Ministry of Community Development, where we are working on the indigents, the poor, to register them. But the other component of stakeholders that have been very, very helpful are the donor communities. They have continued from where they left. They were instrumental in the design of the scheme, instrumental in the financing of pre-incorporation activities, like designing of the benefit package, tours that were done to do studies about this project, financing the initial study that was done to support this project. They've picked up from where they left. As we speak, WHO has continued to support us with what we call an actuarial study. We have an actuary already on the ground. So the donor community, cooperating partners have been very supportive. The unions, Innocent, the unions, if you remember, had one or two pockets of concern.
We'll get there. I still want to emphasize on that aspect between the public as well as the private sector. There are two employees here, those that are working from the private sector, a person like me, yes, in the private sector. There are also individuals from the public sector, and as well as employers.
Yes.
In terms of percentages, which sector would you say you are getting much better support from the private and private?
Innocent, every contribution that comes into the fund is very vital and very important. In terms of proportion, yeah, about 30% of our members are from the public sector, right, and 70% are from the private sector. We're hoping that as we flag off the registration of the informal sector, the informal sector will come and create a well-balanced portfolio. It's important that the number of members in the scheme gets to at least 3 million. We are at about 1.1 million. And the balance is going to come from the informal sector. And Innocent, like I said, it's important that Zambians understand that the scheme is precipiced on 3 vertices, 3 corners of a triangle. The first one is solidarity. We want you who is working now to support someone who may be unfortunate and they are not working. Within those that are working, there are those that earn more and those that earn less. So 1% would be smaller for someone and larger for someone. But when you go to the hospital, we want you to access health care not on the basis of the ngwe you contributed, but on your health needs. So my auntie in Kalingalinga, my sister in Kalingalinga, who contributed 50 kwacha per month, and Innocent who contributed 200 kwacha per month, when she goes for a cesarean section, she will receive treatment. Solidarity is crucial. So very, very important. So whether you are public, whether you are private, solidarity. Secondly, we are also saying that we need now to protect you from what we call catastrophic or impoverishing expenditure. So when you go to the hospital, we want you not to pay anything. Innocent, the average collections we are making from our people is starting from 50 kwacha per month, sometimes 200 on average, 60, 70 kwacha. You can clearly see that the key issue with NHIMA is not to impose a heavy burden on what you are paying. But because we have a huge pool of 3 million people, then those small contributions are large enough for you to go to the hospital. We are also saying that by the time that you get to your age 65, you may have not consumed a lot of your contributions. But the moment you get to age 65, we exempt you. So it's almost like a bank that you are putting across. So we want, number one, to make sure that there's solidarity. Number two, we want to ensure that we protect you from catastrophic expenditure. Innocent, some of the reasons our people are going to Shylocks is because there's a medical bill to pay. Your wife is just delivered. She's just been delivered. And the hospital says, we will not discharge you until you pay. What do? You go to a bank, it will take 3 months. So you go to a Shylock to get money, and you become impoverished. The last precipice we are talking about is, with these resources that we've brought into hospitals, how can we now increase the level of service in hospitals? How can our health care delivery be of a higher quality to impact your socio-economic affairs? And that's why you see the DG and his team constantly going to hospitals to check, making sure that what we had agreed at the beginning in terms of how they look after you when you go to the hospital is adhered to.
Right. For the viewers, in case you've just joined us, this is Assignment with me, Innocent Piri, live on Muvi TV from Zambia's capital city, Lusaka. And of course, we are discussing matters of health. My guest on the program is James Kapesa, who happens to be the Director General under the Zambia National Health Insurance Management Authority, NHIMA. He's here to respond to a number of questions that you, the viewers, have been anticipating to hear in a long time now. Let's now go to one of the critical questions that you attempted 2 times to respond, the issue of resistance. I remember when this institution was about to be established, or this act was about to be enacted, there were a lot of resistance, rejections, and I'm glad that you are speaking to a person who went in the fields and speak to people, cover several protests where people said no from inception. We do not want this so-called NHIMA to exist because these are the people that are going to come and steal our money. Zambians are already poor, and we cannot bring in another institution that is going to be collecting money on behalf of the citizens. Suffice to mention that it took government magnanimity to stand up and went ahead to enact this institution now. Where are we now in terms of reconciliation with those institutions, more especially the civil service unions?
Innocent, where I come from, there's a proverb which says, he who walks you through the night is thanked at dawn. He who walks you through the darkness of night is congratulated or commended at dawn. This simply means that as leaders of this country, sometimes we may be placed in a position where we have to make very tough and difficult decisions under the conviction that this is what is good for our people. And this is what exactly you see in this government. Government had done wide consultations and research. Government had discovered that no country develops significantly and consistently without a bedrock called the National Health Insurance Scheme, which is mandatory. They had done their homework. And so when it was now time for us to move on the ground,
Sure.
I would think that there were still pockets of knowledge in one or two of our stakeholders. And so we then decided that this is a moment that calls for courage. And government, with foresight and courage, decided to go ahead. Today, as we speak, we haven't answered all the questions because the scheme is still in its infancy.
Right.
But if I may use the analog of a farmer, the seed which was buried in the ground is not visible, and people are saying nothing has happened because the seed is still underground, has now germinated. So we can now see the green shoots of that seed. Some of the pockets of resistance were public service unions, and we've continued to engage them in the last 1.5 years. We just had an indaba with them where, as a key and critical stakeholder, we had to go back to them and give them an update on
When
what
you
we are.
say them, DJ, which institutions really?
These are
Would
public.
you point out, say we went to this institution and sat, to discuss with them these matters? Which ones?
We invited all the public service unions
Right.
to a location away from the hustle and bustle of our offices. We gave them a detailed update of what we have been doing from the time we started, but we are also candid enough to share with them what we have done well, what we have struggled to do, and the hurdles that we see ahead. And when they saw the work that has gone into the ground, of course there were areas of concern, but most of the major points of difference were ironed out. And so far, we have continued to have warmer relationships with public service unions. Innocent, that's not the only stakeholder. We have, in the last 1.5 years, met church organizations. All the major church organizations, we have personally met them to explain to them where we are, to receive their feedback, and to also incorporate their concerns as we go forward. We are continuously talking to the employers. We are continuously talking to institutions of higher learning. We are continuously talking to the vulnerable. We are continuously talking to traditional leaders so that we do not leave anyone. Because what we discovered, after we now give our people feedback, is that the source of resistance was not that the scheme was bad. The prime source of resistance was information gap. So far, so good. Have we resolved all the challenges? No. This is a massive project.
Because I remember ZCTU, I think, was one of the big institutions that went on rampage and decampaigning this crusade. I remember some of the ways that were being used by leaders from ZCTU were describing this process and the leaders behind it as savages. Very strong words. I remember Jau's president, Peter Mwale, at that point, he threatened advising his members not to allow you people to go and collect money from them. He threatened actually to sue you together with the government.
So, Innocent, what then happens is that individual members from these institutions are afflicted with a colossal, costly illness. They go to Levi Mwanawasa, they go to Chipata Teaching Hospital, okay, and they are welcomed by a NHIMA member service assistant with a smile. They are told, you are a NHIMA member, this is where you should wait for service. In the twinkling of the eye, they have seen a consultant. In the twinkling of the eye, they've been attended to. heaven forbid and peradventure, they are admitted. They are shown a separate NHIMA ward, innocent. And the bill comes. The bill is, we have testimonies of one of our members who needed what are called pacemakers implants into their heart. You know, our doctors are able to do sophisticated operations, heart operations. So it should have costed this member 85,000. And they're just about to start making calls home to sell their house or to sell their cattle or vehicle. And then the doctor says, no, you're on NHIMA. NHIMA is going to foot the bill. That member goes back to the union and says, look, I've only contributed 120 kwacha since the scheme started. I've only contributed 600 kwacha since the scheme started. I would have paid 85,000 kwacha. Innocent, is that a tax or is that a benefit? You should have paid 85,000. You should have sold your farm. You should have sold your vehicle, but you've only contributed 300 kwacha. Is that a cost? Is that a tax? So now what starts to happen is members start to go back to their formations and say, no, actually this thing is working. And you see, as leaders, we then don't go back and say, we told you. As leaders, that's not our portion. As leaders, we go back to our fellow leaders and say, look, we could have had differences because of an information gap. What other areas do you think we can still do better? So we've been able to still go back to the institutions and say, look, your member has profited, has benefited, but you are still a partner. We had an engagement and an encounter with Comrade Peter, and when we shared a platform with him and shared with him some of these things we are doing, he said, DG, you need to continuously engage me. You need to continuously give us this information because there's an information gap. In short, we discovered, and we are discovering, that the more we engage our partners, the more information we give them, the more adjectives and name calling ends. Because you see, this is about our people. This is about saying, how can we make sure that my sister in Mtendere, who is selling at Mtendere market, contributes a 30 kwacha, and she receives good quality care. This project, Innocent, is about saying, the calls you receive from Chipata or Lundazi to say, no, your auntie has been admitted, send 300 kwacha. We don't want you to be sending those 300 kwachas. And even our colleagues who had challenges with the scheme do receive calls from the villages to say, no, your auntie has just been admitted. We need money for medicine. Send 300 kwacha. NHIMA is here to ensure that those out-of-pocket payments that you've been making without counting them are reduced. In short, we've continued to receive more support, continuous support from all our partners. Have we resolved their problems completely? No. Because this project is part of continuous progress. We are improving it as we are going. And so we are still open to criticism. We're still open to feedback. At NHIMA, Innocent, feedback, adverse or favorable, is what grows us, is what makes us better.
Right. Let's talk about the issue of accountability, something that you briefly talked about it, but I would deliberately ask you again, because I know that we are dealing with the monies here.
Yes.
In a country where a lot of people are jobless, the economy is very tough on several citizens in this country, and yet we've got an institution that, of course, is trying by all means to secure the lives or the health of people through the contributions that you're supposed to make to NHIMA. Let's talk about how accountable you are in this institution. Once again, I want to remind you that we are living in a country where if you are going to go to the Auditor General's report of maybe last year, you're going to see huge sums of money that have gone missing. You check in the Ministry of Health as well, reports are there that so much money always goes missing, just like in the other institutions. And the people of Zambia that have no interest to contribute to NHIMA. As you speak, as you face into that camera, how honest are you that you are indeed an honest person and honest people to be accountable to these funds?
Innocent, the first thing that we need to address here is that as leaders, we must listen to a story 3 times, such that some of the stories that we find in the news, in the media, as leaders, yourself and myself, have to take a deep breath and ensure that the message, the news, is correct. And so, what is the blueprint for accountability at NHIMA? The blueprint for accountability at NHIMA starts, first of all, from the board. Okay? A board which is selected deliberately to encompass all the key stakeholders. Employers, representatives of employers in public, representatives of employers in private, representatives of workers in public, workers in private. Ministry of Health is represented. Ministry of Labor is represented. Ministry of Community Development represented. Ministry of Finance, and you as a member of the public well represented on this board. Professionals, Innocent. And so the board sits and creates rules. And remember, this is separate from government. So we can't say, no, we haven't done this because of this and that. The board is in charge. Secondly, as management, we now say, what are the policies we need to do? We have an internal audit department, Innocent, whose job is to daily check and report, not to me, to the board, if there's anything untoward that we are doing, to the board.
That happens on a daily basis.
Well, we have a team in here on a daily basis. Right. To them. Of course, the reporting to the board is quarterly, but nothing stops our internal audit function. You see, we are a very young institution, but the board said from day one, we're going to have an internal audit function. Innocent, we also under the watchful eye of Auditor General. Again, we're just about 1.5 years old operational. Again, the board said, DG, don't wait for the things to accumulate. Go to Auditor General's office and ask them to come so that all the issues around accountability, you take off as an authority together with support from Auditor General. So at NHIMA, Office of the Auditor General are value added to us. They are partners. So they are already on site. And as part of how open we are. And like I said, Innocent, we have attempted at every space, at every opportunity, to go to the public and announce how many people we've registered and how much we've collected. We have also endeavored at various points to announce to the public how much money we have sent to the hospitals, so that when you go to Petauke District Hospital and leaders there say we do not have medications, you should be able to say no. But I just heard that from DG that they sent you 200,000 kwacha. Where is my money? This is the kind of environment. You see, accountability is a mixture of personal honesty, which you talked about, but most importantly, systems. Most importantly, an environment. So we've created an environment, we've created systems, and we've created individuals who working within systems, working within the board, and with the broader government supporting us. We do not so far have any headaches around accountability.
Let's move on to the availability of drugs. I know that this is one of the factors, major factors, when it comes to the issues to deal with health delivery. You know, what is NHIMA doing? How are you, handling these matters?
The issue of drugs is topical, and this is a good question that you have asked, and I know you are asking it on behalf of the public.
Indeed.
We go back from the conception of NHIMA. Remember that NHIMA needed to come and bridge a gap. NHIMA is not supplanting government or Ministry of Health from funding and managing hospitals. So NHIMA supplements, doesn't supplant government. So Ministry of Health, through Central Treasury, continues to fund the provision of drugs, the provision of medical consumables in the hospitals. NHIMA comes to top up So we are a top-up arrangement. And so when you speak of the concept of drugs, when we started the scheme, we sat down with public hospitals, and they said, DG, we will need, before we receive your members who are now paying, they would require a bit more attention. DG, are we able to agree on what is called an advance payment? So the board of NHIMA coalesced and quickly gave us a policy to now go and support hospitals with advance payments to buy drugs. And so by February, March, April last year, hospitals started receiving resources from NHIMA in terms of soft loans to pay back, to prepare for drugs when you go to the hospital. Now, of course, on the ground, we still had challenges. The board then said, DG, we need to make a quick plan here. Are we able to bring private pharmacies, private pharmacies on board quickly, September 2020? So as we speak, just in case there is no medicines at Livingstone Teaching Hospital, just in case there is no medical consumables at Mazabuka General Hospital, NHIMA has a network of private pharmacies. You can therefore receive a prescription from a doctor, and with that prescription go into town, into Cairo Road, with any one of our accredited pharmacy and get the medication resolved without making any payment. That is where we are now. But the broader goal is for us to ensure that as we put funding in the hospitals, as we send money to the hospitals, and as some hospitals have now started claiming and receiving monthly resources from NHIMA, you will start to see the challenge of medical stockouts. And as government continues to invest in the hospitals, you'll start to see the challenge of medicine stockouts slowly ebbing away. Is it a problem we are resolving now? Of course not. Is it a problem that you will see consistently get better? Yes, that's why NHIMA is there.
Right. DG, I understand and I sympathize with you that you are coming at a time where when the world is battling with the COVID-19 pandemic, you are 3 years old, in the office, or 2 years old in the office, but regardless of that, the people of Zambia are still demanding to see your performance. You and your board as well, they want to see why this institution was established. Very critical indeed, and I sympathize with you. But regardless of that, again, the people of Zambia have got nothing to, have got nothing to, no excuse at all, because that's a job that we chose. Tell me how your institution has been affected by the COVID-19, the plague that has shattered a lot of sectors. You can talk about football fraternity as well, got affected. You can talk about the education sector as well. At some point, it was closed. Almost all the sectors of the economy were shut. And here you are existing. You've got a lot of ideas that you have highlighted, but are you likely to achieve these things with the pandemic that we have at hand? How have we managed, first of all, let's begin with, how have we managed to contain this?
Innocent, we appreciate your sympathy. We need a lot of it, and this is a mammoth project that our people have bequeathed on us, and it's a source of pride. Immense pride and humility for me and for the 40 or so and our other project partners who have been given this rare opportunity by our people to commence a project that will transform their lives. Even when we face a headache, when we face a challenge, we still find it humbling. A rare honor, high privilege. So thank you for your sympathy, and I think it's well placed. We decided from day one, and through the support of the ministry, government, and the board of NHIMA, that we will run NHIMA as a business. Now, that shouldn't worry our people. This is not about profit. The basic model for a business is that you provide value to the members. So we are very clear about the need for us, come rain or sunshine, to deliver verifiable value to our people. By March 2020, we were ready to get into, we were ready to get into the market. We were ready to flood our towns. We were ready to get into the bus stations to start registering our members and to start creating awareness campaigns. And just like that, COVID was in our midst. We had to roll back our plans. That meant that the number of people we should have registered reduced. It meant that the collections that we had to make had to reduce. It meant that a number of companies who were targeted to be our members, to register members on our behalf, folded up. Some of them were insolvent, some of them closed. So it affected how much we budgeted to collect. It affected how many members we were bringing on board. On the other side, it also meant that there was additional pressure on the hospital system. It means that the amount of attention, drugs, processes, procedures were escalated. So on both sides, on the revenue side and on the cost side, we saw some adverse progress. How have we coped and how are we intending to cope? So Innocent, what we then did was that we then went into our business model and said, if option 1 has challenges, we then trigger option 2. And option 2 for us was then to say, fine, then for every 1 kwacha that we receive, because we are now receiving less, we need to aggressively invest it. Invest it in the money markets so that there is additional revenue, interest and revenue that comes to the fund. In that way, we bridged that gap. We also said, instead of, for example, deploying 150 people to go and start the registration through our partner project called ZISC, we then had to double the number of people that must go into the market. Internally, we also said, hold on, we are not collecting the same amount of money. We had this budget to spend. Director Finance and Investments, we have to tighten the cost expenditure. Innocent, we are cost conscious at NHIMA. We are very frugal. There is a popular saying at NHIMA where we say we are very lean and thin and mean. Lean, thin, and mean. And the idea is that for every 1 cost we should have spent, we always ask a question. What ways can we save this money? And so far, budget faces costs. Because of the pandemic, we are always below the budget to create that extra room. Now, these are business ideas that we are putting in place. And overall, we have a very robust performance management culture at NHIMA. Every 3 months, everyone at NHIMA stops, drops what they are doing, and they have to say, how have I performed for the last 3 months? They are sitting with their supervisors, and I receive the report as Director General. I look at my director's performance, and if you have not performed, they are very difficult conversations. We give you time to improve. If you don't improve, there are consequences. So all these things have helped us to create a performance-based culture and also to ensure that at the head of our intentions, you as a member, you as a contributor, receive the best service.
Let's talk about the other plans that you are intending to implement at NHIMA. Very critical indeed. People, I think, would want to hear from you some of the plans that you've highlighted, of course, just for the sake of the reminder, for the people that have just joined us right now. What other plans remain unimplemented as we speak? As you answer that question again, I wanted to also talk about the staff that you have at NHIMA, because one of the critical components at the center of health delivery is the competence among members of staff. What is there in terms of human development?
First things first, Innocent, we have what we're calling the Big 5 ideas, Big 5 projects that we are working on and that portend the future of NHIMA. The first one speaks around registration. Right now, we are at above 1 million. We need to get to 3.5 members. Right. The biggest idea we have now is readiness, working with other partners, government institutions and agencies to register the informal sector. So we want to send a message to everyone who is in the informal sector to get ready, to start registration so that we don't leave you behind. Attached to that, Innocent, is registration of the indigents, those who are on social cash transfer are judged by the Ministry of Community Development as vulnerable. They must be onboarded on the scheme because they are protected by the Act. The other big thing we are doing is now open branches of NHIMA in the provinces and in the districts. As we speak, we've opened 10 provincial offices and 2 additional regional offices. This has massive implications for the presence of NHIMA and the awareness program for NHIMA. For example, if you go to Kabwe, you'll find that we have 10 NHIMA officers stationed in Kabwe. Their task day to day is to have a full list of businesses that are operating in Kabwe, and day to day go door to door to these businesses to encourage them to register. And as they are talking to them, they are discussing what NHIMA is about. So this is happening in all the provincial centers. The next step, Innocent, is for us to now pick 2-3 economically active districts and send our members there. Massive project. We have also received approval from the board to go into the hospitals and support hospitals with medical equipment. One of the things we noticed, Innocent, and received in terms of a complaint system is that some of the hospitals are well equipped with medical and imaging and diagnostic equipment. Some of them are not. In other instances, there will be equipment, but because it is overwhelmed by traffic, so it breaks down consistently, and therefore, the experience that our members have when they go to public hospitals and accredited hospitals is suboptimal. So the board of NHIMA said, management, let us go into the hospitals and partner with them to invest resources into medical equipment. So we're hoping that in the next few months, you will start to see the challenges of dysfunctional medical equipment, diagnostic equipment like X-ray, ultrasound, CT scans should start to become a thing of the past. Big issue for us. Innocent, the other one that's very important to our people is that as we continue to accredit hospitals, government is commissioning mini hospitals. Mini hospitals are sitting between a district hospital and in cases where there are new districts, where there are no district hospitals. NHIMA, working with the Ministry of Health, is about to start accrediting mini hospitals so that the network of members that profit and benefit from NHIMA improves. On top of that, Innocent, private hospitals, in the next week or 2, we will be announcing a list of private hospitals that are now going to be able to provide services under NHIMA, meaning you will have an option. You will have a choice if you are in Mansa to go to a private hospital as a teacher. You will have a choice if you are in Livingstone to go to a private hospital or go to a government hospital. Massive projects that we are working on.
Meaning you are equal as well, contributing to the employment levels as well.
Massively. Massively.
With an aim to reduce unemployment in the
Massively. And we're also taking development to rural areas that are off the line of rail. Because remember that if I can get a private hospital, even in a peri-urban area here, in Kalingalinga, if I can get a private hospital that is on NHIMA, in Mutendere, it means that our teachers, our officers, our marketeers who are queuing up at a public hospital can go to that hospital. Do you know what it does? It decongests my public hospitals. And because there are fewer people there, quality improves. Our health workers are not as stressed. But most importantly, healthcare facilities progressively get closer and closer to our people.
We have to go, DG. We've got a few should-be minutes remaining, but we are going to try by all means to squeeze in 2 or 3 questions before we close the program. For the viewers that are watching us, you are watching The Assignment with me, Innocent Piri from Zambia's capital city, Lusaka. And of course, my guest on the program is James Kapesa, who happens to be the National Health Insurance Management Authority, NHIMA, is here to respond to a number of questions that you, the viewers, have been waiting to hear from the people involved into that authority. DG, let's go to the other issue, which is the universal health, universal coverage. I know that this is a long term that government has been working on for a long time now. And this is a vision of 2030 in which you want by 2030 at least the Zambian people, at least the majority should be in good health. But it's critical indeed because there are so many challenges. The economy is not okay. You've responded specifically about the COVID-19, but generally the economy is not impressive enough. Is it attainable, really? Or how sustainable is this universal health coverage by 2030?
The target and the goal to attain universal health coverage by 2030 is within our grasp, is within our reach. This is 2021.
Sure.
We've got 9 years before we can get to universal health coverage. For people who are listening to us, universal health coverage in simple terms is that every Zambian has health insurance, meaning that when they are born to the time they die, they must be fully covered, meaning when they go to the hospital, they would have been making a small prepayment on a monthly basis, 30, 40, 50 kwacha, 100 kwacha, 200 kwacha, some from their pay slip, some like the informal sector through a payment using a mobile phone, have been making this contribution. And when they go to a hospital, they should not pay anything. And so this is achievable. And Innocent, it is achievable because the signs so far in the last 1 to 2 years have been more than encouraging. We started NHIMA at a base position where government was saying only 4%, just about 4% of Zambians had some kind of cover health-wise. Now, that's very dangerous and unfair. It's a very unfair scenario where for every 100 Zambians, only 4 had access to health insurance. The other 96, it's survival of the fittest. And you see, you can't build a prosperous economy on the basis of 4 out of 100 people. So government boldly and courageously said, no, enough is enough. We need to broaden this number to make sure that by 2030, when Zambia becomes prosperous, it means that Zambia's people must be productive. And you can't be productive if you are unwell. This is what has been happening to our people. They feel a headache because they are scared, they don't have money, they either self-treat, or they don't even go to the hospital. They only go to a hospital when things are worse, and we then lose them. Or because they took long to get to the hospital, it takes longer for our physicians and health workers to treat them. With NHIMA, that is going to be a thing of the past. Where we sit today, we have moved technically, Innocent, from 4% to 40% in 2 years. This gives us confidence. This gives us energy and motivation that if we work at the same pace, more and more partners like yourselves come on board to create awareness for our people, we will be able to achieve the goal of universal health coverage within our lifetime. And for me as DG and NHIMA and my team, we are saying if we can do this even far ahead of 2030, that will be bonus and kudos for our people. So to answer the question categorically, yes, government has got the passion, the leadership, partners like unions are now on board. Media like you are now aware of the scheme and are supporting us. Cooperating partners have been giving us support, and the board and the team at NHIMA are ready to go. So universal health coverage is possible, Innocent, in our lifetime.
You've got 9 years before the year 2030, like you've mentioned. As we speak, some of the people out of the over 18 million Zambians are still unable to access quality health care in Zambia. How sure are you that by 2030 we are going to be somewhere as a nation?
We have, first of all, we are assured by the plans that government through the 7th National Development Plan, which are tracked at cabinet level quarterly, There is a lot of work that is happening under the 8th National Development Plan. There is a lot of planning happening at the Ministry of Health. If you look at the Ministry of Health is looking to roll out in the next couple of years over 108 mini hospitals. 30 of them have already will be commissioned this year. Specialized hospitals, Innocent, are happening. Remember that health posts have also been rolled out in the country. There is a lot of training happening for health workers, a lot of colleges, and Ministry of Health is employed close to 25,000 workers in the last 4 years. Right. All these things are pointing to a determined government providing health to its people. When you now come and top this up with the arrival of NHIMA now providing impetus to the hospitals to up the quality that they provide. That will be your closing
remarks. We have to go. Sure.
Upping the quality of health, injecting additional resources, and creating a kind of a watchdog, because you are paying. The game has changed in terms of how we deliver health care. My message to our people is that if you are not registered, please go to the nearest NHIMA health point for you to be registered. If you are indigent, if you are vulnerable, don't give up, we are coming. And for all those employers who have not yet remitted their payments to NHIMA, those who are not contributing but they have registered, don't forget that NHIMA is law, and we are putting in place compliance measures. Soon and very soon, we will come over to you, and hopefully you would have complied by then, because we now have capacity to sue and take you to court for hospitals that are not giving good quality. Right. Our message to you is that the window period to work with you, to support you, is coming to an end. Right. Lower quality, we de-accredit you and take you to court.
DJ, allow me to appreciate you on behalf of the Zambian people for coming, and we pray to the Almighty God that we continue seeing more of these programs for the betterment, for the better health of our people of Zambia. We appreciate you once again. Thank you.
Thank you so much, Innocent, and thank you for our people that have supported NHIMA in the last 2 years.
Thank you so much. Dear viewers, we end our discussion here. My guest has been James Kapesa, who happens to be the National Health Insurance Management Authority, NHIMA, Director General. Of course, I'm sure he's managed to respond to almost all the questions that we've had. If he hasn't, he's just a human being. I'm sure next time you'll be able to do better. My name is Innocent Piri on behalf of my producer, Mavuto Piri. Thank you so much. May God bless Zambia. May God bless Mother Africa. Good night.